allowed in. Okay. Good evening, everyone. Thank you for joining us. This is Ashkan Lashkari speaking. I'm president of MOASC, and I'm honored to lead off our second year of our lung cancer webinar series that we have moderated by Dr. Hatim Hussein, Associate Professor of Medicine and specializing in thoracic oncology at UC San Diego. And tonight we have two panelists that are also members of the University of California Alliance, if you will, Dr. Jonathan Goldman from UCLA, Associate Professor, as well as Dr. Jonathan Rees, Associate Professor at UC Davis, both of whom are specialists in lung cancer treatment. And I did want to also mention that our webinar is sponsored by Janssen Oncology, and so we're appreciative of their support and helping us put this together. Dr. Hussein, I'll send it over to you. Thank you, everyone.
Thank you.
And one final housekeeping issue: if you have questions, feel free to place them in the chat room, and I'll make sure that the questions are addressed. And please do so. This is meant to be an interactive webinar. Dr. Hussein, it's all yours.
Thank you, Dr. Lashkari, and it truly is a great honor and pleasure to have fellow colleagues who are really truly experts in EGFR field here participating with us in meeting and speaking today about EGFR mutation landscape in non-small cell lung cancer. As Dr. Lashkari has mentioned, actually, we're going to focus on classical mutations, but some of the principles apply broadly across atypical mutations. And so when opportunities come to even bring up those, I think it would be a great opportunity to speak about that. So again, really a true honor and pleasure to have Dr. Jonathan Goldman from UCLA and Dr. Jonathan Rees from UC Davis. And maybe actually, as I refer to each, actually, I may say Jonathan G and Jonathan R, to kind of, just to kind of make sure that we're all, kind of, on the same page. Apologize about kind of some of the shifts in the slides here. So with further ado,
it sound like we're in kindergarten. Calling us Jonathan G and Jonathan R.
Yeah, I don't think we've been in this circumstance before, so it's kind of interesting. Maybe you guys have been together on panels before, though. No, I'm not sure. Anyway,
yeah, we have, but I don't remember the solution.
Okay, so we're going to start actually with patient of mine, and I like to kind of pick this because it really highlights just how large of an impact EGFR tyrosine kinase inhibitors have had in EGFR mutant disease. And this is one of my patients who's 72 years old, who within 2 weeks of a third generation EGFR medicine, which at the time was, still in development, we saw such a dramatic reduction in cancer early and upfront. And, this patient actually remained on the medicine for a substantial period of time. And in fact, actually, one thing I may ask actually you both is to say, in recounting some of your patients, can you tell us actually what the longest time a patient has been on an EGFR TKI? Granted, some of these may have been earlier generation, progression or kind of such, but in your practice, how long is the longest patient been on an EGFR TKI?
I go back to almost the beginning, soon after fellowship, so 2008 or 9. And she actually switched from erlotinib to osimertinib at some point for toxicity management. And I should say along the way, we've had to do some radiation and there have been some issues, but actually right now she's NED for several years.
Wow. So then she started the TKI in 2008 and now it's 2023 and she's still on an EGFR TKI.
Right.
Wow. That's actually long.
There must be something different about disease like that.
Yeah, no, that's interesting, actually. So Jonathan, Jonathan R, actually, would you say kind of, we've been practicing similar durations of time. I mean, what's kind of the longest that you've had so far?
I have a handful. I mean, I have one going around, I guess, over 12 years that I actually inherited from one of my colleagues. Now, he's subsequently progressed, but is still on erlotinib. He was T790M negative, so we kept him on erlotinib and added treatment. But he was on it over a decade before he progressed. I have another patient. I have a couple of oligometastatic patients that I've treated that are still that we were kind of aggressive in terms of treating oligometastatic disease, that are still on erlotinib kind of NED. And I'm, based on data, if you look, some of the trials extrapolating from the adjuvant setting, when you pull it off, you release the brakes and it comes back. Even though they're NED, they're tolerating it well. And, they're my age, and I'm not taking them off ever unless the reason comes up. They'll be with it hopefully another 20, 30, 40 years or more.
Yeah, no, super, super interesting. And I will say, probably the longest patient I've had has been about that 10-year range. And interestingly, the patient that I had, started with, really symptomatic brain metastases, needing actually decompression, getting ultimately radiation. And one of the interesting things about that particular patient is, at the time, she was, she was kind of being treated in a practice where they hadn't done EGFR testing. So in fact, actually, after the decompression, the radiation for the surgical bed in the brain, and then actually she was given chemotherapy. And then actually we found, I saw her pretty soon after that, we did a molecular test, found EGFR, and started at that time erlotinib. And now she's still doing well with NED. I think kind of some important points, and the reason why I'm mentioning this is to say, I think in our practices now, and love to hear from other oncologists on the panel, this concept of survivorship in the EGFR mutant patient population. Patients are living longer periods of time. I have another patient actually who has had leptomeningeal disease now for probably over 5 or 6 years, and that is also somewhat atypical, but reflects this point that people are living with this disease for longer periods of time. And then the next point, actually, which we'll talk about, is kind of this concept of earlier intervention with chemo, and kind of what does that actually mean. And so kind of with that context, actually, let's go on to the next slide here, which really kind of just highlights the fact actually that lung cancer continuously evolving, even since the last time we have spoken. There's been FDA approvals across medicines, including HER2, additional approvals in the KRAS G12C, PDUFA dates and kind of considerations around novel ROS1 inhibitors, additional agents in these spaces. So I think we're going to, have an interesting year, even kind of going forward, reflecting on things. In the EGFR category, again, different cohorts have different percentages. I feel like these pie charts can sometimes be deceptive, because here in California, in some of our practices, I would say the EGFR category even, is dramatically higher. And, I think in previous discussions, we've reflected upon this. May I ask, actually, Jonathan Goldman, actually, in your practice, what would you say is the distribution of EGFR mutant disease? Kind of if you were to give a percentage.
Yeah, it's really a maybe even like the plurality of patients. We definitely have lower smoking rates, a large Asian population, and there's a referral bias to a tertiary center. So at least a third. Also the extended survivor status, so they're going to accumulate. So a third, but sometimes a half of patients will be EGFR patients.
Yeah.
In a clinic day, for example.
Yeah. And Jonathan Reese, I'm sure it's probably the same for you as well, right?
Yeah, it's real similar, but I would say about half EGFR for the same reasons.
Mhm.
Sometimes I joke with the fellows at the end of clinic that, when they join me for clinic that, oh, nobody got chemo today. It was all targeted therapies or immunotherapy. So,
Yeah.
look how far we've come. 3/4 of my patients are on a targeted therapy and another quarter on immunotherapy, and nobody's on chemo.
Yeah. I may actually just broaden this out a bit, and I see Dr. Bora and Dr. Jang on. Firstly, thank you so much, for joining us here. It's really great to get your insights as well. So please, do, kind of interject, ask, kind of, we can all kind of, make this very, interactive. But Dr. Bora, I may ask you actually, in your practice in the community, would you say that this is similar? Like, are you seeing about half EGFR as well? Or what is kind of that patient profile or demographic?
It's a good question. I'm surprised by the number half or the fraction half. We're not there. I mean, I think I'm in Long Beach, and there's still a lot of that old school smoking sort of shipyard type of population that we see, a lot of elderly Caucasian men coming in with lung cancer. So it's not as frequent. I would love to say that half my patients with lung cancer are EGFR mutants or have a cancer that's an EGFR mutant, but I think it's less than that in our population.
No, thank you so much. And firstly, so it's so good to see you after so long. Yeah. And Dr. Jang, actually, I may ask you the same question, actually, kind of in your practice, in the lung cancer patients that you're seeing, would you say that it's such a high percentage of EGFR, or kind of, what do you think about it?
My practice, is very similar to the pie chart. I would say about 25%, 25% of the patients are EGFR mutated. So I don't, I don't know, maybe our patient population, we see KRAS, we see, other mutation, but I would say EGFR to me is about 25%, which is very similar to the pie chart.
It's so interesting because geographically we're only like, at least from you to Dr. Goldman, 60 miles maybe.
Yeah.
From Dr. Bora to Dr. Goldman is probably less, like a lot less. And so, it's interesting just to think how even Southern California is geographically defined here, and how maybe in some of these, academic centers versus the, community centers, how the population also is different. So just some interesting reflections there. So now, just some questions about this. I think, what is essentially important in a discussion of EGFR is a discussion of molecular testing. And I think that, some important points that we continue to reflect upon over the years is the role for broader sequencing versus, more specific sequencing within the gene of interest. And in the context of EGFR, we've learned now that, there's diversity with mutations. And actually, Jonathan Rees, your take on this, because you were kind of starting to talk about this a little bit, about the just the number and variety and heterogeneity of EGFR with mutations. Do you mind telling us a little bit about what you were saying about, how even with classical mutations versus the atypical mutations, how there can be different responsiveness with EGFR TKIs, and kind of, what implication you see that has for the type of molecular test, meaning NGS versus PCR, things like that.
Oh, I think that's a great question. So, I would start out by saying, I think, I think NGS is the standard of care over PCR. And, for EGFR mutations, the most common ones you'll find are the exon 19 deletion and L858R. And those were the ones that, were specifically studied in Flora, that showed that, PFS and OS benefit over earlier generation, erlotinib and gefitinib and so forth. But you have less common mutations. For example, EGFR exon 20 insertions. You now have approval of 2 drugs in the second line setting, after chemo, because, the response rates aren't as robust as osimertinib in the more typical mutations. But, amivantamab, response rate of about 40%, PFS of about 7 months. Mobocertinib, response rate about 28% in trials, PFS of about a little bit less than 7 months, but higher duration of response, at least according to the trials. Well, pretty similar overall, not like I said, as good as osimertinib and common EGFR mutations, but those exon 20 insertions are very heterogeneous. There's like over 100 that have been described. So you really want to do NGS to pick those up. They're typically not sensitive to osimertinib except for the proximal FQEA mutation. So if you find that on your NGS report, you can give them osimertinib with confidence. But otherwise, you're looking at second-line treatment after platinum-based chemo with AMI or MOBO. I don't give IO in these patients, at least as single agents or just with carboplatin and pemetrexed. I don't think, they get much, and they were excluded from a lot of the pivotal keynote studies. And then in terms of other less common mutations, we were just talking about it before, you've got that set of 3 of, L861Q, G719, and S768I, where afatinib is approved. I would say, we've done some research as well as others that I think have really shown that the L861Q does comparably well on osimertinib as the common EGFR mutations. So I give those folks OSI. I don't think we know enough about S768I, so I often give them OSI, although afatinib is a reasonable choice. And G719, kind of those PAC mutations, I think either afatinib or OSI. I often give afatinib if they don't have brain mets. If they do have brain mets, I give osimertinib and get an early scan. They don't, but I think either or for that one. I use brain mets as my deciding factor, and I discuss with the patient. If I give OSI, I often get a early scan. So that's kind of my management of these patients. I would just emphasize it's really important to get NGS before committing to IO. If you give them Pembro and then you find an EGFR mutation, then you switch to OSI, high rates of pneumonitis and kind of potentiation of adverse events. So if I'm really pressed to treat, I give a cycle of chemo while waiting for the NGS. If it's negative for EGFR, ALK, and so forth, then I add the Pembro with cycle 2. I'd love to hear how others manage these folks.
Can I ask a question, Dr. Reese, regarding the first part of your discussion on some of these atypical EGFR mutations? When they're reported on these NGS diagnostic reports, whatever it may be, we don't necessarily get the benefit of what you just mentioned in terms of like what TKI might be more ideal for that individual. And let's say if it's in a typical exon 18 mutation for which osimertinib may be a benefit. I forget the one that you had mentioned. That's not something that would necessarily be recorded on that on the diagnostic report, right? That would be something we'd have to kind of either look up or discuss with someone who knows more than I do in regards to that. Is that right?
I mean, they'll like list the group of. I think it depends on the vendor, but I mean, yeah, they'll list that set of EGFR drugs. Yeah. So I think, but for exon 20, I think you got the. I mean, usually they'll indicate exon 20, but I agree sometimes it's confusing. But yeah, for exon 20, definitely the AMI and the MOBO. But then, like I said, the nuance kind of is the FQEA. If you see FQEA at the end, then they're sensitive to OSI. And then, like I said, those 3 sets of uncommons, you have afatinib approved. But I really use OSI with the exception of the G719, where I think it's a toss-up, but I think they don't do as well with OSI compared to the other ones. So afatinib is a very reasonable option in those patients. I use brain mets to differentiate for those patients. But I think there's no wrong answer there between afatinib and OSI. But I'd love to hear what others do. It's kind of, yeah, but you're right. I mean, if a lot of those, I agree, it can be confusing. And for the rarer ones, that there could be more information provided in those reports.
I really like actually your consideration about how to perhaps stratify some of the medicines around the brain metastasis angle, in the atypical space. I think that's actually a very interesting, practical way to think about things.
It's really the G719s that I the other ones I give OSI to. Like I said, I'm on the fence about the G719s because they they do a bit worse with OSI, and afatinib's the FDA approved choice. So that's where, as you point out, the CNS disease and some other considerations. If you look, there was this, I mean, to get into the weeds, but MD Anderson published those G719s they're considered part of those PAC mutations that were shown kind of in their preclinically not to be quite as sensitive to OSI. So yeah, so that's how I look at it. Jonathan G, what do you do? I'd love to hear what you do.
A lot similar. Just kind of took some notes. You really laid it out very well there. One thing we do a little bit differently is partly due to the high rates of EGFR and the delay in getting an NGS report. We do a rapid PCR. The IDILA PCR comes back in 2 or 3 days, and it only takes a couple of slides. So that works out very well for us to capture a lot of the patients. We see it all the time, that challenge of getting a high PD-L1 in adenocarcinoma, wanting to pull the trigger on pembrolizumab, but I can't agree with you more or enough that that at least ruling out EGFR, I think, is really important. We also do an ALK IHC to get that test, evaluated quickly. But we are really depending on NGS to pick up the rare EGFR mutations. I also believe that the exon 18 G719X, excuse me, my camera fell. Picking up those are important because the older drugs didn't work that well. Osimertinib definitely has less binding. So if you're not worried about CNS penetration, I think afatinib is a better drug. It's a harder toxicity drug, so I have that discussion carefully with patients. I think Ashkan brought up such a challenge in modern oncology that within each field, even within lung cancer, there's a lot to stay on top of. I will often do just a PubMed search. I think targeted therapy for lung cancer, preclinical data really is quite predictive in many cases for clinical efficacy. There's a few exceptions, but you can see preclinically that afatinib inhibits G719 much better than osimertinib. And so I do use techniques like that if I'm trying to pick the best drug. And in the end, I don't know how much extra time it takes, but certainly during a busy clinic day, it's hard to step over to a computer and pull that out. We have, for the most part, gone to osimertinib for almost all of our patients, and part of it is that CNS protection that is good. And as a team, and the slide that you showed, patients feel better within 10 days often or less, and so that's been such a gratifying part of modern oncology.
And I think it's an interesting point you brought up with your quick panel. I used to do that, but before we use circulating tumor DNA, we don't have in-house testing for it, but I'd be on the phone with Clarion or Response Genetics or something like, patients in the unit, I need this now, and they'd be nice enough to expedite it for the next day if you beg them and so forth. But, I don't know how much, it's great that you do that. We don't have we don't have that in-house testing that you have for that. I generally have instead done, like a Garden or one of plasma circulating tumor DNA, because I feel like we get those results not in 3 days, but in a week. I'll send up the test and do that. I'm just curious how everybody else uses circulating tumor DNA. I feel like I'm ordering it more and more and ordering both, based on data showing increased yield, and it's just gratifying to the patient who wants to start treatment yesterday. You see them a week later with an EGFR, you could potentially shave up to 3 weeks off their workup or more. Yeah,
I completely agree. Sometimes it's a little bit of a question of, are we really doing, a $5,000 panel on the tissue and a $5,000 panel on the blood? But given, how important these are, how it's a proper care, how sick patients are, and how expensive the rest of our care is, I do generally take that approach. But the rapid PCR has been really useful. The ALK IHC is a very cheap test, and that's been very useful. But in a non-smoker, we are often rushing the ctDNA also.
I'm actually glad you brought that up because we're having trouble, with that molecular testing waiting in the hospital and stuff. So now that you bring it up, we've been sending them out, but I may ask our pathologist if they could develop kind of at least, like a rapid panel in-house that we wouldn't be dependent on given the insurance stuff when they're in the hospital. That's a great point. I'm gonna take that back to our pathologist.
Well, thank you both, actually. And, I think it, really is, shows kind of, some of the tensions around time to a test result, getting the best test that one can in the most feasible way to provide an early indication of where to proceed. I will also actually just say, I think Dr. Bora has had a question over here. Firstly, Dr. Bora, thank you so much for sharing, kind of this question. Maybe I'll let you, kind of talk about your case, because I think it may be good to kind of get the feedback, of our panel here for this, because it's not intuitive, it's not concrete, and how one may proceed.
I appreciate that. It's an interesting case in that he came to me. It's a very healthy man. He's of Indian origin. And he came to me because he had a cardiac CT scan that showed a lung mass. He ended up having stage 2 lung cancer that was resected. And I gave him adjuvant Alimta carboplatin. And then during the molecular workup, this was a couple of years ago, I found out that he had an EGFR exon 18 mutation. And so I didn't know what to do at that point. I kind of pulled all my experts and talked about whether there's a role for adjuvant, EGFR inhibitor in that case. And I remember talking to Dr. Salguia over at City of Hope, and he was like, there's not really data on that particular mutation. So I would just do observation. So he's been on observation for the last 3 years, and he's unfortunately had 3 intracranial recurrences. And after the first one, he had surgery, and I, post-surgery ended up putting him on osimertinib 80 milligrams. And sort of since that time period, he's had 2 more recurrences, and each time he's either been radiated or resected, depending on the location. So currently he is, there's no evidence of any type of disease in his brain, and systemically he's been clear. And Jonathan, you mentioned the G719A mutation. That was a particular mutation he had. And so my question for now is, what do? I still have him on 80 of OC. I've tried to get him onto 160 of OC because I saw some data on that in a very small case study, but insurance denied me there. So I've had trouble changing. Would anybody change now to afatinib or just wait for another recurrence, or how should I proceed?
Well, I think you're spot on with the, if he's NED, I agree. I would have done the same thing. I would say, well, maybe going to 160 would provide enhanced CNS penetration. That's been studied in the Bloom trial. It's unfortunate that insurance didn't approve it. I would have done the exact same thing. Given the lack of CNS penetration of afatinib, I probably wouldn't switch him. And I don't think after progression on OSI, it's hard to know how much afatinib would be helpful. That there are pulse methods of giving afatinib. We've given it, for example, like, 240 once weekly. But that has its own set of side effects, and he's NED. So I probably would just stay the course and see if there's any way to fight insurance to get to 160. I'd probably just I would expect it to be negative, but I may send off a circulating tumor DNA just to see if you detect any resistance mutation to osimertinib. I think your chances of finding it are pretty low, but you never know. He may be still being shed some DNA, and has he acquired a MEDAMP or something else? Not clear what you would act upon it though, but I'd be curious about that. I probably, with being NED, I probably wouldn't do anything else. I would note, we have the trial open at UC Davis, and I believe there's Southern California sites for furmonertinib. So that's a trial we have open. It's approved in China, but they've titrated up the dose and has some exon 20 and atypical mutation activity. So it's specifically being studied for G719 and other similar structural mutations called PAC mutations. And that has very good CNS penetration, and it's a higher dose than what it was approved for in China. It binds to a different site on the EGFR tyrosine kinase domain than OSI. So I'd probably see, I know that I think Long Beach has a site. So I may look to a clinical trial, should he recur. If he does recur too, I mean, pemetrexed-based therapy has blood-brain barrier penetration, but those would be my thoughts overall, but I think you're spot on.
Okay, that's helpful. Thank you.
And I would just add, you could do NGS on the resected brain tumor. That might give you that resistance information.
I'm sorry, but I did every single time, and it's always been the same looking tumor. I haven't seen any change.
I think although osimertinib was this great step forward in CNS protection and treatment, there still are patients where you hit a recurrent problem there, and there's not a great solution. At some point, the patient might need to go to whole brain or something like that, and it's very painful as a treating doctor when, in a way, that you've got such good systemic control, but in the brain a problem. I wonder whether, if at the time of brain recurrence in the future, that might instigate the insurance company to pay for it at that point, and you might try that for 2 months before going to surgery, and see whether that could help treat the known brain met and prevent other ones. But it also isn't so easy. Some people have a hard time sticking with that and anorexia and weight loss.
Okay, thanks.
I will actually just say, while you guys were speaking, actually, I kind of looked up just to see if there was any available data on dual TKIs in the setting, and kind of, is there any data for osimertinib plus afatinib in this? So apparently this month there was published a study of afatinib plus osimertinib in the treatment of osimertinib resistant non-small cell lung cancer, a phase 1 study published in the British Medical British BMC Cancer. So apparently, in this study that was done primarily ex-US, they enrolled 13 patients, and basically their conclusion from this is that the tolerability was tolerable, and I'll read to you kind of the percentages of the AEs, but it had limited systemic response. And so the diarrhea rate was 77%, anemia 77%, rash 69%. And so the recommended dose of afatinib that was used was 20 milligrams, osimertinib 80. Response rate was about 8%. So just curious, kind of in our discussion over here, that there was a trial that was actually published looking at this in a combinatorial strategy, granted high rates of toxicity. But
there's a report of temozolomide with osimertinib in this problem of trying to get CNS treatment. And I've done that before, but unfortunately, and not really done many of these things for too long. Even if you get a benefit, it tends to not last more than a few months.
Yeah, I tried it once in the scenario afatinib and osimertinib, and I'll reluctant to do it again. And there was a rationale behind it. Basically, the patient had a resistance mutation to osimertinib that was resistant to 1st and 3rd gen, but was sensitive to afatinib. So I put her on she was elderly, so I put her on afatinib at 20 milligrams, and she responded systemically nicely, had a great response, but then developed brain mets. But was responding systemically. So I said, not one you could just SRS. I mean, multiple where you'd have to do whole brain. And so I talked with some other colleagues. I came up with this kind of on and off OSI and afatinib, and she just totally crashed with it. And I modified the doses. I mean, I don't remember the exact dosing scheme, but it was thoughtful, and it just crashed and burned. And so I'd be reluctant to do it. And then now she's just on observation. She doesn't want to do any EGFR TKIs. So,
and it's curious, actually, there are some other published reports looking at this intercalated dosing using one inhibitor and another. May I ask, actually, Jonathan Rees, actually, what was the resistance mutation that you were looking at that, was
I don't remember it exact. I think it was G some. I don't remember the exact
Okay.
one offhand. I think it started with a G.
Because I remember, I remember I remember when the early reports of C797, I remember there being a push to consider that afatinib may have some, at least preclinical efficacy against that mutation. Just as an incidental note, now there are ongoing studies looking at gefitinib combination with osimertinib in the setting of C797S. Again, these are first-line studies looking to more prevent the occurrence of C797S with osimertinib in the front line.
And we have an arm of Jonathan G has it open too. The Orchard trial has an arm for C797 with osimertinib and gefitinib, and I've given it off-label too. I mean, that's much more tolerable than afatinib. I've given it for C797S. I've seen responses. They don't tend to be particularly long-lasting, but I have some patients on it. There's new C797 inhibitors in development. There's the Blueprint one. There's kind of others coming down the pike that look interesting. I think seem to have at least preclinical activity. I think that the chat, to my mind, when we were back in the days of first line erlotinib and gefitinib and afatinib, you'd give that, and then the majority of patients would have T790M, and you'd get that, you'd give them osimertinib, and you'd have a high response rate in that setting as opposed to T790M negative. I mean, now C797 is what, like maybe 15%, kind of maybe even a little less.
Or less, I think.
And so, you have all these bypass tracks. So, you have a C797 drug, but that's not going to apply to the breadth of population that, the T790M did with osimertinib.
Yeah, it's a much more similar situation to ALK mutation or ALK fusion, where the resistance pathways are myriad. Jonathan, talks about MET amplification, and there's several trials and combinations adding in a MET inhibitor. Many of us have seen some rare fusions. Like I have a RET fusion patient who went through a series of very interesting treatments, went to osimertinib with selpercatinib, and then developed a mutation that was resistant to selpercatinib, so then went on the Turning Point second generation RET inhibitor. So she had 2 single patient IND trials, responded to every one, but it's very hard to practice medicine that way. And unless some of these 4th gen TKIs are also better against the driving mutations and other pathways, it's hard to see them being easily used.
And I think, I think that's somewhat appealing. You have, like, for example, the HER3 antibody drug conjugate, where, the response rate's about almost about 40%, PFS 9 months, median PFS, I think about 9 months or so. And theoretically, if you're doing an ADC and delivering a chemo payload, the tumor heterogeneity shouldn't matter. It might, but I mean, theoretically, it'd be
not as much. Yeah.
What kind of, I think some of those drugs, including the HER3 ADC, may get approved because it's not going to have super duper blockbuster activity, but still in that setting, 9-month PFS is pretty darn good. And so I think that's where some of these ADCs and other things will come in and be options for our EGFR patients.
I totally agree. And then there's the TROP2 ADC, another approach. So I think that is a good broad-based therapy that can help a big segment of the pie.
Yeah. No, thank you all. I think kind of this was really, a good representation. And I think, we'll kind of jump to that point now of, I think we've established that EGFR, it's heterogeneous disease, can be heterogeneous with the original EGFR mutation. And I think some of the nuances that, that both you have kind of highlighted with regard to efficacy, as well as, perhaps CNS considerations, I think are really important. think it's also important to recognize actually that not only are individual mutations within EGFR important, but also the concomitant mutations that are seen with EGFR mutations is important. We know that P53 can co-occur with EGFR in this cohort, about 56%. Other RTKs, MAP kinase gene, cyclin-dependent kinase genes, these can all co-occur and may have implications on some of the biology of the cancers as well.
Oh, Hatem, can I just mention something real quick? I would just say, going back to co-mutations, there's P53 we see in a lot of cancers. You'll sometimes come across P53 and RB1 that are co-mutated, and they have a much higher rate of small cell transformation. So when patients progress on OSI, the odds ratio is like 20 plus in terms of, compared to no P53 RB1 in terms of small cell transformation. So, if you come across those, I always tissue biopsy those at progression on osimertinib, because those are the ones that get the small cell transformation. You'll see it described in the literature. Honestly, I think it's a little bit overblown in terms of the percentages, but it's real. And so those are the patients I actually make sure I get a tissue biopsy on progression.
Yeah, I think super important point. And there are clinical trials now kind of looking at this concept of, with the specific type of co-alteration, is there an earlier intervention that can be done to help mitigate or kind of intervene, anticipating that maybe kind of there could be a specific type of resistance. But I will actually just say this is, unfortunately, we're currently not at a vantage point to predict which type of resistance a patient will have from the beginning. That would be truly a holy grail if we could, have that granularity of consideration to say, we start with osimertinib with this specific genomic profile, there will be this type of resistance that happens. I think there are some clues that can be obtained with P53 and RB. But truly the holy grail would be, can we predict which patients will have MAP kinase dependencies in the future? Will there be an acquired fusion event? Are there specific genotypes or signatures that can help us in that way? And I think, as we get more information about the serial analysis over time, I think that will be helpful. It's actually kind of pertinent for this figure that I have here, which is, something that we created to kind of look at how on top of different selective pressure, there could be acquired mutations that happen. I think this is interesting because, this may be what is happening actually in people on the medicines, where there can be acquired mutations as second site mutations in EGFR, and then medicines, like in this case, osimertinib, given after previous generation inhibitors, where one can, see within EGFR resistance or outside of EGFR resistance, meaning bypass mechanisms, that can happen. And this figure just shows.
Don't you think the bypass mechanism, like a MET amplification, happened much earlier than the EGFR mutation here? So if the patient progress, chances are you have to address the MET amplification first. I mean, they happen about 12 months or so, and the EGFR mutation happened about 18 months or later, right? So
yeah, you bring up such an interesting point, Dr. Chang. I think this is actually, truly an important thing that, I can tell you're a connoisseur of the EGFR here, partly because, if you look at this figure, right? So this is from a paper in 2019 by Jeff Oxnard, kind of looking at the time on osimertinib, depending on what type of resistance the patient had. So you bring up such an important point that if a patient is going to have, or in this cohort at least, if a patient had acquired EGFR mutations as the mechanism of resistance, the time on osimertinib was longer than if they had a MET amplification or the small cell transformation, or in this case, actually, it was PI3 kinase plus small cell, but I thought this was actually very interesting, partly because it really gives us this reflection point of, for people who are on osimertinib for longer periods of time, kind of what is that resistance? And I may actually ask our panel, Jonathan Goldman and Jonathan Rees, what, now that you guys have been, we all have been using osimertinib for longer periods of time, do you kind of notice a specific profile of the patients who are on the medicine longer in terms of when they resist, kind of what type of resistance it is versus not?
One thing I'd say first is that there is a big difference between the first-line osimertinib patient that we're seeing now and the ones like in this report who got a first-line, first-gen EGFR inhibitor. Many of them had T790M, but not all of them, and then went on to osimertinib. I think that we see a lot more C797S in that situation in a different pie chart, whereas the first-line osimertinib patients, they really, it's like totally myriad. Like each, there's so many different ways that they can develop resistance that although the PFS is better, developing a next generation is even harder. I think kind of on a patient-by-patient basis, it's really hard, to predict how long they're going to do. TP53 we mentioned is a bad prognostic factor, but I do have some that are on OC for 3+ years with TP53, and so I find it difficult to select, for example, who should go on a trial. We have a trial of patritumab, the HER3 ADC in the first line. And so that's in addition to osimertinib. And for that patient, they're taking on a lot more toxicity, visiting the office every 3 weeks compared to osimertinib alone. And theoretically, the people that should look at that are the higher risk patients with TP53 mutations, for example. But how good a predictor that is for an individual is not clear to me, I think. And there's certainly exceptions. I do think in general, exon 19 deletions do better than L858R by a few months. So that might be an additional factor you could look at. Do you see it differently?
It's interesting, actually. I do feel actually in our cohort and would love to kind of work together on the UC consortium, perhaps kind of in different ways. Now, even on this call, we have 3 UCs somewhat represented, here, where it'd be nice to kind of look at our patients who have been on osimertinib for greater than 3 years and our patients who have been on osimertinib for less than 3 years. And really kind of now, the maturity of the drug is enough where we have enough patients who are, going through that life cycle. I think before, in prior times, when the medicine was more recently approved, we had, at the time that this paper was created, 2019, the medicine had only been, in use for a shorter period of time, and so that may have skewed some of the results. But I think that you're right. This is a second-line study. Generating the type of data for the first line would be interesting. As an anecdotal experience, I will say that if I think about my early progressors, there are people that have some other either oncogene that is associated. They perhaps have a different histology, like squamous with an EGFR mutant kind of mutation, or they've had some prognostic kind of component, whether it be CDKN2A, P53, or as Jonathan Rees has mentioned, kind of P53 and RB1 loss. But I think a great opportunity for us all to work together, assembling our data sets and maybe dichotomizing those greater than 3 years and those less than 3 years, and maybe making a pie chart for each.
Well, I think, I agree. I would, just to follow up on Dr. Zhang's comment, they did present some data recently, and where Dr. Zhang, I think, was spot on, where, they looked at a Guardant data set with circulating tumor DNA, and they saw that the patients that recurred within a year had a higher proportion of MET amplification, and those that recurred later on, had a higher proportion of C797. So, to Dr. Zhang's point, there does seem to be some differences, and like Hatham was saying, histologic, squamous, some of these co-mutations, P53RB1, histologic transformation, and sometimes you see squamous, EGFR mutation from the get-go, that kind of lineage plasticity, and then, MEDAMP and these bypass tracks do tend to occur earlier, and then you get the on-target mutations later. So there does seem to be some clear differences, but to Jonathan Goldman's point, it's kind of like a box of chocolates. You don't really know what you're going to get. So I think, I think there's a whole host of mechanisms of bypass tracks, RET fusions, ALK fusions, RAS-RAF MAP kinase alterations, and a whole host of on-target mutations. And it's more heterogeneous than when you started off with first gen and then got T790M and then did OSI and then got kind of that spectrum, totally different spectrum, although there is some overlap. The frequencies are different.
What's amazing is just to realize how rich the EGFR field is, that we've spent so much time kind of, getting to this point now, which is actually talking about
Well, I mean, there's ALK too, right? I mean, there's ALK that's less frequent.
I feel like,
and there's all those mutations, and there's that kind of like heat map that looks like, I think Christine Lovely compared it to like a Sanford guy that we use for like, when we were residents and med students to pick out antibiotics, and you do that for ALK inhibitors. So there's all, there's so much to keep track of now, but I think, there's some broad themes and in terms of looking things up to match to either, an on target or other drug or clinical trial. So, but a lot of these patients, for practical purposes, first line osimertinib, the majority of patients are getting platinum pemetrexed second line, regardless. But there are some mutations that are actionable in the resistance setting right now.
I think super interesting, and I think it really just highlights how rich the EGFR field is, that even in an hour, we're kind of just scratching the surface on some of these points. I may ask, actually, just because in the interest of time, we're kind of running close to time, that I did have some other, I think, practical questions that I think would be good, maybe in a kind of lightning type of way, just to kind of, highlight. I think some questions that I think are pertinent, and Dr. Jang and Dr. Vora, please let us know too, if you feel like these questions are actually pertinent in your practices and, kind of doing that. But I thought some of the ones that could be important are, what we're doing in the second line after OC. Are we combining chemo and a TKI post-progression or not? And I also wanted to address this point about, in general, how does one feel about the number of lines of therapy an EGFR mutant patient is getting? Maybe if we just tackle those three right now with our panelists. Actually, Jonathan Goldman, what do you feel about with these three questions? Do you feel like if you'd be able to kind of just make some comments there, that would be helpful?
Yeah, I mean, I think these are really the cutting edge and important questions that we face every day. Second line, I do like to look for clinical trials, absolutely. I do think that ctDNA is a great use here, as is biopsy to rule out small cell and getting NGS testing. And if I do see, one of those, either true MET amplification, I may add on a MET inhibitor, or a new fusion like RET fusion, I'll add on a RET inhibitor. But I think in the absence of trials, in the absence of some specific direction, I think chemotherapy has to be our standard, somewhat unfortunately, but is an important part of our therapy that helps most of our patients. Unless a patient has brain mets, pre-existing brain mets or progressing with brain mets, I'm not sure that we really know that continuing the TKI leads to better outcomes. So I am comfortable with chemotherapy alone. I also do like the Empower 150 regimen, carboplatin, paclitaxel, bevacizumab, and atezolizumab. The data in under 100 patients, but look pretty good in the EGFR mutants, and they get done with the chemotherapy pretty quickly. And I also think there are rare patients, hard to predict, with EGFR mutations that do well with immunotherapy. So I think there's all those benefits to that regimen, as long as you can get over the hair loss and the neuropathy. I think and then after that, I often try going back to osimertinib, possibly in a novel combination on trial. But even osimertinib in a patient that's been off of TKI can do well. There have been case reports and case series of patients getting many repeat lines of EGFR TKI, often responding repeatedly. I don't get to docetaxel ramucirumab that often, but I think it's a really valid choice. There's some evidence that ramucirumab, like bevacizumab, may be particularly effective in EGFR mutants, and I think it's a valid choice, especially when you don't have clinical trials. And then on the last one, I have a basic general policy of not using monotherapy immunotherapy in EGFR mutants. I think the rate of rapid progression and ending up in the hospital in 4 weeks with really impossible to manage disease is just too high. And so that's part of why I like doing that Empower 150 regimen. I know the patients will have sort of the protection of the chemotherapy while we're seeing if immunotherapy, while we're seeing if they might be in that small group of EGFR mutants that do well on immune therapy.
And actually,
Great
John,
question.
I may just ask you about that. Actually, with the Empower 150, when you give the immune therapy there, are you seeing any long-term responses, like any kind of that would suggest that the actual immune therapy is creating some durability beyond the chemotherapy?
Yes, I think so. I mean, you are also getting the bevacizumab in there, and maybe that's part of the benefit. But I have a small handful. One patient who got nivolumab and just for years had a totally different disease course, was rapidly progressing with leptomeningeal disease, actually. Expected survival is measured in weeks. And literally many years later, we're still doing well. And I don't think that PD-L1 is a very good predictor. I wonder if PMB, or there might be some other, maybe it's the people with smoking exposure in addition to the EGFR mutation. I don't think we've been very good at picking out who those patients are. But I think if I remember correctly, the response rate is real. It's around 8% or 8 to 10% with EGFR mutations, but it's not zero. Hard to distinguish whether how it would compare to other oncogene-driven populations like ALK, for example. But I believe that there is some patient that's doing well with immunotherapy in EGFR mutation.
Yeah, no, thank you for those comments. Actually, Jonathan Rees, actually, any additional thoughts or kind of considerations that you would?
No, I think I kind of agree with everything Jonathan G said. I probably continue OSI with carbopem a little more frequently, certainly for brain mets. If they're tolerating it well, I often keep it going as well. So probably a little, but practice similarly. Obviously, if they've had any struggles with it, I feel totally comfortable outside of brain mets just doing carboplatin. I've had a couple. I do the same thing with immunotherapy. I occasionally use Empower 150, and I have seen anecdotally good results. I often give carbopem first, but I have used it and seen good responses there. I also never give single agent IO to these patients, although I have seen a couple patients in consult, like, who got Pembro and responded, and then they check an EGFR and it's positive. And you're like, well, I totally would never have done that or recommended it, but the patient seems to be doing fine. So, but I think that's the exception rather than the rule.
No, thank you so much, actually. And I will actually just also interject that I did a reflection, recently on the number of patients and how many lines of therapy different patients were receiving. And I was actually quite amazed by the fact that EGFR mutant cohort in my practice seemed to be the one that was getting the most lines of therapy. And in fact, actually, I think the median was about like 4 or so. And so, these patients are getting therapies, maybe a reflection of the fact that they may be living longer. This goes into that survivorship component that we were talking about before. Dr. Jang, any thoughts you have here? It'd be great to get your thoughts on your EGFR patients.
For me?
Yes. Yeah. Sorry to put you on the spot.
Oh, okay.
Actually.
No, I just want to say something about this. Number one is, I think you say the first question is the strategy of second line. I think the definition of second line is actually quite important. Number one is second line could be, are you having a primary resistance to the EGFR therapy, right? That's a second line. But that way, if you have primary resistance, I think you're looking at systemic chemotherapy here, in my opinion. So that's number one. And number two is maybe your second line. And the reason why I mentioned about the MET amplification happened earlier is if your second line is because you have a bypass pathway in the MET amplification, then I think you should tackle that first. And recently I saw a lot of different data, especially the one, I think the trial is called the Insight 2. They have 88 patients, phase 2, using tepotinib plus osimertinib, and with 55% response rate here. So my thinking about it is, you go into the battle, what you got to define what your battle is right now. So that would be my approach if you find a MET amplification. If you don't, then I guess you're looking at the later on target mutations. Then I think you should look at into the, you could think about whether you're going to go the chemotherapy route, which, you guys mentioned the Empower study or ramucirumab. That's all reasonable. Or you could also think about the tumor agnostic route, right? So tumor agnostic route would be, you could think about Resected plus, amivantamab, right? That's one of the tumor agnostic approach. And somebody already mentioned about the patritumab or the datopotamab, or maybe eventually sacituzumab is maybe coming too, right? These are the TROP2, which, I treat breast cancer too, so I have a lot of experience with saci myself. It's an excellent drugs, and it works. So that's kind of, I'm looking at the second line. The final comment I want to see how the panel people think about is another second line. Somebody mentioned about 15% small cell transformations. My thinking is how many people actually continue osimertinib while they go into the platinum VP16, or do you stop the osi and just switch over to the chemo part? That I don't know, but I'm wondering how do people do here. But my bottom line is, second line, there's many different second line, and we got to have a right definition for what are you dealing with.
And if I could just add really quickly onto that, I'm so glad you framed it in that way. Think about, the oligo progression patients with a single new lung lesion or brain met that could be treated with targeted radiation but continue on the osimertinib. There's all different kinds of progression. The small cell transformation question, I ask myself that question every single time I see one of these patients, and I have tended not to continue the osimertinib. And then you have the additional question of, is there a benefit to going on atezolizumab or durvalumab? And I don't think we know any of those answers. There's been, in the Orchard trial, which Adam just put up, there was a group that got a PD-L1 inhibitor, and there's coming a group that would continue osimertinib, but it's non-comparative. I don't know how specifically instructive that data is going to be, but I think it'll probably be the only data that I'm aware of. In my personal practice, I have not continued the osimertinib. It has not been useful for me, at any line once there's small cell transformation. And I have given durvalumab or atezolizumab, thinking that the toxicity rate with that regimen, the additional toxicity is very low. But I think the data, we're almost in a data-free zone there.
But do you put patient back? Let's say you switch them to chemo or platinum VP, and they went to complete remission, and after that, do you put them back on osimertinib?
I've never had that good luck of getting a complete remission. I think you're in a great situation then. Maybe you've somehow cleaned up the high-grade disease and you're back to non-small cell lung cancer. But I haven't seen that myself.
No, but I think really great question, Dr. Jiang, and I think Dr. Goldman, really great points around, this first question about, truly the second line is heterogeneous. The strategy can be heterogeneous. think one overarching view that I took away, Jonathan Goldman, was about the fact actually that we should be thinking about small cell, and that prompts a biopsy, and really kind of not losing sight of the fact that in an EGFR mutant patient, or any patient actually with a targeted therapy, those patients may be well served with some type of genomic surveillance at the time of progression. It can be optimal with tissue, and tissue is still kind of a great way to assess specifically for small cell. And kind of commonly we are doing plasma as well. And so really kind of getting a genotype to help understand, the next line can be helpful. I think radiation was a great point when applicable. Perhaps actually, Dr. Jang, in your comment around, what are the opportunities for a more definitive response, even in a small cell transformation patient, radiation could be, something of use there. Dr. Alicia Sequest has a review kind of looking at immune therapy as a consideration in the acquired small cell. Unfortunately, kind of immune therapy didn't work so well. They had a subset of even nivolumab and ipi-nivo as well, kind of in these types of considerations. It didn't seem to kind of work. But I think some bottom line points, and maybe just to wrap up then, firstly, I think, genomic testing is very important. Keeping the genomic test as an opportunity, even at the time of progression, is important. These patients are getting multiple lines. So really helping a patient navigate in those later lines is essential. Clinical trials can be a great way to help patients navigate. In the subsequent webinar, we're going to have more of kind of a discussion on drugs in development. But I think some ones to note here that have been noted are amivantamab, that's being studied with TKI in the context of progression, and looking at certain patients post-progression, actually also even kind of doing some stratification based on MET amplification, as well as C797 or other acquired EGFR mutations. Patritumumab, anti-HER3 ADC, also being looked at. Combinations of the study in the Orchard study, which has been mentioned, which there's multiple cohorts being evaluated. I think kind of, these are just some. This is from an older slide. But I think, kind of really highlighting the fact that a lot of investment happening to try to figure out where are we going to go to post-osimertinib, and now novel therapies like ADCs that are being integrated. So any other final last thoughts before we close, Dr. Reese and Dr. Goldman, on your viewpoints here? Anything kind of that you feel would be great to close with?
A great discussion. Really enjoyed it.
Yeah,
thanks
for having me.
Yeah. No, thank you. And thank you both for your great contributions for many of these slides, actually, where, some of the work that you guys have done have represented here. I will actually just make a note of osimertinib and necitumumab. I think Dr. Reese, you were, kind of very instrumental on how this actually even got integrated into the Orchard. And then Dr. Goldman, many of all your works actually in the EGFR space that have, changed. Anything at UCLA that you guys are recommending for trial post osimertinib right now?
We have two ADC trials, one with patritumab and one with depalumab. We have some MET inhibitor combinations. We've run the savolitinib combination trial, and AbbVie has a MET ADC. We're probably just finishing up the phase 1-2 trial and hoping to develop a phase 3 trial. But the anti-MET ADC, which has some activity beyond just true MET amplification to any MET overexpressing resistance. And so that's going to be a larger part of the Venn diagram. I'm running a trial that certainly has its toxicities. It's osimertinib, necitumumab, and trastuzumab, based on some crosstalk between HER1 and HER2. And we definitely are seeing some rash and diarrhea and seeing some responses, but we're in the midst of that evaluation. I think those are the ones that we're most excited about, and try to keep on. It's such a we have so many patients. It's such an important part of our portfolio.
Yeah, and I will also just end with one trial that we have at UCSD, which is looking at osimertinib and abemaciclib, particularly kind of with the recognition that many of these patients have cell cycle gene aberrations that are concomitant. And so, another study actually that we're, very excited about and kind of have open here at UCSD as an IST. Well, thank you. And actually, Dr. Laskari, I'll let you kind of close the meeting.
Yeah, thank you so much, everyone. This was a wonderful discussion. I think we all learned a lot, and I think the other exciting thing is that there's so much going on in this field. Just hearing about all the different possibilities in regards to second-line trials outside of what can be conventionally used just gives our patients a lot of hope, and that this is, not one disease. Even in the second line, it seems to stratify into multiple diseases potentially based on their resistance mechanism. So I want to thank Dr. Hussain for moderating, and Dr. Reese and Dr. Goldman, the two Jonathans, for participating as our panelists, and to the rest of our esteemed audience members who contributed, Dr. Jang, Dr. Vora. Thank you guys. And we'll see you next month. And we're looking forward to it. I think next month we're scheduled on the, I have to look at the schedule here. I don't know, Cole, if you have.
It's going to be for Elk and Ross.
Actually. Oh, Elk and Ross. Thank you very much. So so our next talk is going to be continuing on the targeted pathways. We'll see you then. Thank you.
Thanks so much. Take care.
Thank you guys. Bye-bye.